This program is brought to you by Emory Healthcare.
I think that you will see either a medical oncologist, a radiation oncologist, or one of us as urologists. And even though we have specialty interests in those areas, we try to approach the problem as broadly as we can. And so when you come in for an assessment, we'll discuss all the different treatment options that are available and define which ones would be better for you as an individual. We try to sort of give the patient several choices because it can be very confusing. The number of treatments for prostate cancer is very long, and to say that there's one treatment that works for everyone is really not true. And so we don't try to fit everyone into one niche or fit them into one mold. We really try to maybe fit the treatment to the patient. So, for instance, if we talk about radiation options, there are different types. You can get just external beam radiation all alone. You can get radioactive seeds implanted all alone. You can get both of them done. External beam first, followed by seeds. Some groups use the seeds first, followed by external beam. In our particular case, we find that there are fewer side effects if the radiation is given first and then followed by the radioactive seeds. So again, those kind of treatments for radiation are appropriate for some patients, but depending on their urinary symptoms and their perception of radiation, some people may totally disagree with using radiation treatment, and they may pursue surgery or freezing, cryotherapy. So we do have different things to consider in each patient, and we review them. I think what we offer is we offer the full range of different treatment options. I don't think that the idea that there's only one treatment for any patient with prostate cancer is true. I think every patient has a unique set of medical comorbidities, let's say, other illnesses that they have. They certainly have their own health history, and they have a family history. And a lot of what we deal with is longevity. And longevity is in long part not dependent so much on what you do or what you eat and what medicines you take, but a lot of it is already predetermined by the genes that your parents have given you. So if someone has a very favorable genetic history, then those are patients, provided that they've taken reasonably good care of themselves, those are patients where some of the more aggressive treatments may be appropriate even though they're relatively older. And on the other hand, we may have some young patients who have other medical problems like diabetes and heart disease, and even though they're relatively young, certain treatments may not be appropriate for them based on age. While we talk about the same treatments with every patient, some of them are totally inappropriate for certain individuals. For instance, an option of just following the disease called active surveillance is much more appropriate for the older patient that may have some medical problems. On the other hand, some of the younger patients may be more interested in the less aggressive treatments, but in the long run, those will come back to hurt them if they don't have the more aggressive treatments when they are young. If anything, when patients come and see me, they've usually seen one or two other physicians, if not more. And one of the things I can pretty much tell them with sort of a tongue-in-cheek, but not really, is that if they think they're confused to start off with, I can make it more confusing because I can offer other treatment options that they may not have considered. And again, we're not trying to confuse patients, but we're trying to give them an idea of how many choices they do have. And in large part, prostate cancer is not an emergency disease in the sense that you do not have to do anything emergently. So I encourage patients to do their homework, to spend their time talking with family and other patients and other physicians. and let them process this information over a period of time and then make decisions after they've had a time to sleep on it for a while. Because the tendency is for people to rush in, want to get an answer right away, and sort of decide immediately what to do and rush in and have it done. And those are the situations where we often find that patients are not pleased with the outcomes, because there's not a single treatment that is available that does not have any side effects. And if the patients have done their homework, have been prepared, then the side effects are very minor. But if patients sort of rush in and have something done, then even the most minor issues that occur get magnified into big problems. And again, it's all patient preparation and awareness, and we get everybody through the treatments well. But again, there will be some bumps in the road, and if people are prepared for it, then the bumps are very minor. Some of the things that we do in the actual treatments, the robotic technology is very popular. It's been around for about 7 or 8 years. And our robotic surgeons have been getting very favorable results with the robotic surgery. On the other hand, is robotic surgery perfect for everyone? By no means. This is just another way of doing a surgical procedure. And so if someone has good skills with open surgery, they're probably going to get as good results as anyone doing it robotically. The problem is that everyone has marketed the robotic, so everyone moves over to the robotic surgery. But that's certainly available at Emory. The radiation therapy that we have that's different is the Calypso beacons, which is a way of putting basically a GPS seed or beacon directly into the prostate. And that GPS system communicates with the X-ray head, the special X-ray head, so that if there's any particular movement on the patient during the procedure, the radiation can be withheld while the patient, the target, is out of the field. Another treatment that we do here that is somewhat limited in the outside is cryotherapy. I mean, there are people who do cryotherapy in the outside. We have seen patients with very difficult problems who have failed radiation or seeds or surgery, and we have done salvage cryotherapy on those patients. So we've had a very favorable experience with that too. We have a tumor board that meets twice a month that consists of multiple disciplines: the urologist, the radiation oncologist, the medical oncologist, the pathologist, the radiologist, and even the interventional radiologist. We have this large meeting where all the major tumor cases are presented, and the slides of the biopsies are reviewed. The x-rays, imagings that are done for those patients to stage them are reviewed. And then we reach a consensus as to what the best treatment approach for that particular patient is. And so I think that serves the patient best in the sense of everyone looking at the information at the same time. And it's remarkable how much interplay we get between the pathologists and the clinicians, because the assumption is the pathologist just looks at the slides and that's it. But we find that the pathologists are often where the opinions are changed the most is actually based on what the pathologist tells us. And more often than not, the pathologist actually teaches us rather than the clinicians go around teaching one another. So I think we do learn a lot at each of these meetings, and I think that translates into better patient care, and I think patients understand that this is not usually a single decision by one physician. It's a collective group of people that have put their heads together and decided this would be the best treatment for that individual.
The preceding program is copyrighted by Emory University.